Thank you very much, Daniel. Thank you very much to the organizers. It's certainly a pleasure to be here and able to share with you today. We'll talk first on some advances in esophageal motility evaluation, specifically with manometry. A couple of disclosures. First, high-resolution manometry and esophageal pressure topography, or Klaus plots, represented an advance in esophageal manometry and have essentially replaced conventional line tracing manometry, as it's allowed improved depiction of characteristics of esophageal motility and also improved ease for interpretation, including improved inter-rater agreement for interpretation, as well as accuracy of interpretation. Esophageal pressure topography provides quantifiable metrics of esophageal function. The IRP measures deglutitive EGJ relaxation pressure. The distal latency measures contractile inhibition. And the distal contractile integral measures contractile vigor. And all of these have aided high-resolution manometry interpretation and are also amenable to application to a hierarchical classification scheme of esophageal motility disorders, the Chicago classification. And now the Chicago classification has provided a standard language and a schema for classification of esophageal motility patterns, and this has been broadly applied and utilized around the world. And included in the Chicago classification is one of the most notable advances that's been afforded by high-resolution manometry, and that is depiction of achalasia, which is defined on high-resolution manometry by an elevated IRP and the absence of peristalsis. And further, this came with the recognition of the potential for subtyping achalasia based on the presence of pressurization or spasm, which is premature contractions. Now, the subtyping of achalasia, which we see here represented by type 1 achalasia with no pressurization, type 2 with panesophageal pressurization, and type 3 or spastic achalasia with these spastic contractions, provides a method to prognosticate response to therapy, such that utilizing this across all types of achalasia therapies, patients with type 2 achalasia have the best treatment outcomes, and patients with type 3 achalasia have the worst responses to therapy. And this has been demonstrated in multiple studies. But perhaps most importantly, these achalasia subtypes carry management implications, and such that when you distinguish spastic achalasia, these patients can be preferentially treated with surgical myotomy, and this yields outcomes that approach those of the non-spastic subtypes. This was best demonstrated by the European achalasia trial, which was a prospective randomized trial of pneumatic dilation versus laparoscopic Heller myotomy. And we can see here, as I mentioned, that with type 3 achalasia, those who had laparoscopic Heller myotomy had similar outcomes to those with type 1 and type 2 achalasia, whereas those treated with pneumatic dilation had significantly lesser potential for a favorable outcome. Thus, myotomy is the preferred treatment option in patients with type 3 achalasia. And further, the novel application of POEM provides the potential to actually tailor therapy and extend the myotomy up the esophageal body and ablate the extent of the spastic segment that can occur in type 3 achalasia. Now, while achalasia represents a significant advance to manometry, beyond achalasia, there are some limitations of earlier versions of the Chicago classification that became even more apparent with broad application. And this posed several questions about how clinically relevant some of these classifications were, or how definitive or conclusive of a clinical diagnosis could be derived from application of the Chicago classification and high-resolution manometry patterns. Additionally worth noting was that the Chicago classification was based on just 10 swallows of small volumes of liquids, and these were performed in a single patient position, often laying down. And so an additional question posed was if that test protocol was truly sufficient to characterize esophageal motor function. And now these limitations were most notable with the classification of EGJ outflow obstruction. And this is a pattern that is commonly observed. About a quarter or more studies completed with high-resolution manometry will have this pattern, and this has the potential for major treatment implications. And the root of the problem with this EGJ outflow obstruction classification is that this does not represent a unique esophageal disorder. This is instead a manometric pattern that encompasses a variety, a heterogeneous spectrum of esophageal motor function and clinical diagnoses. Thus, this EGJ outflow obstruction pattern does not include patients that have, that it does include some patients that have significant and clinically relevant motor function in the form of achalasia variants. And these patients may be appropriate for invasive achalasia type therapies. However, this is seen in the minority of patients who have this pattern. Additionally, though, this EGJ outflow obstruction pattern can also include other important findings, such as subtle mechanical obstruction, hiatal hernia, potentially an opioid effect. But most notably, this can also include patients who have truly normal esophageal motility. And in this case, the elevation of the IRP is solely related to a measurement artifact. And unfortunately, this false positive pressure artifact is quite common and can be more than a third to a half even of some of these cases. And in these cases, application of invasive and potentially irreversible achalasia interventions, such as LAS myotomy, would not be appropriate. Thus, this poses a major challenge. Now, a lot of these limitations are addressed in the recent update of the Chicago classification, version 4.0. And I had the pleasure of working with Daniel and Prakash and about 50 other experts on this consensus effort that was recently published. And the Chicago version 4.0 will be formally launched as part of the upcoming FNM meeting. Of note, registration is free and available online for this upcoming conference. Though I'll still speak to some of the concepts and the data reflected in this version 4.0, even if not directly presenting the classification scheme today. So first is related to the protocol. Earlier versions of the Chicago classification were derived solely from small volume test swallows. And those are typically performed in the supine position. However, numerous other adjunctive and provocative maneuvers with high resolution manometry have been described and applied. This can be involved using manometry in multiple positions, often supine and upright. This can involve a multiple rapid swallow challenge. This can involve a rapid drink challenge. And it can even involve using viscous or solid swallows, and even a solid test meal or monitoring after that meal to try to bring out and evaluate symptoms. First is simply utilization of multiple patient positions, performing bipositional high resolution manometry. And doing so can potentially correct some of the position or angulation of the HRM catheter as it passes through the esophagogastric junction. And this is really important as it can help offset some of this pressure artifact that can create a misleadingly elevated IRP. We did a study looking at applying this bipositional manometry in patients that were classified as EGJ outflow obstruction with supine swallows only. What we demonstrated was that when the IRP normalized in the upright position, this was almost exclusively associated with having a negative esophagram with normal esophageal emptying. And thus this carried a very high negative predictive value and was very useful to help rule out a relevant EGJ outflow obstruction. However, this normalization of the IRP only occurred in about a sixth of these patients. And so this was a very useful rule out test, but remained pretty insufficient to actually rule in EGJ outflow obstruction as a clinically relevant abnormality. Other potential applications here include provocative maneuvers such as multiple rapid swallows, which involves having 5 swallows of a small volume done in a rapid succession. This provides evaluation of a contractile reserve based on this after contraction here. I suspect that this has implications in GERD and ineffective esophageal motility, and so I believe that Dr. Gaiwali may touch upon this in his next talk, so I'll try not to steal his thunder here. But multiple rapid swallows also provides evaluation for outflow obstruction, as with these multiple swallows, which also occurs with the rapid drink challenge, in which patients are given 200 cc's of liquid and told to drink as fast as they can. This induces a robust inhibitory signal to the lower esophageal sphincter, which you can see in this example from a healthy control, where IRP values are very low with both of these maneuvers. In comparison, in achalasia and other disorders with impaired LES relaxation and clinically relevant EGJ obstruction, IRP elevation will persist with these maneuvers, and additionally, pressurization may occur as a manifestation of the EGJ obstruction. We looked at this again in patients that were classified as EGJ outflow obstruction based on an elevated IRP in the supine position, but did not meet criteria for achalasia. And using esophageal retention on a barium esophagram as the outcome measure, it demonstrated that when the IRP remained elevated during both of the maneuvers, both multiple rapid swallow and rapid drink challenge, this provided an increased probability with odds ratios of 3 to 5, depending on the model we applied, to predict an abnormal esophagram. However, as we can see, this still wasn't perfect. And even with persistence and elevation across these maneuvers, not everybody had an abnormal esophagram, and normal esophagams could occur when these both had normalized. Another test maneuver that's been proposed is using the solid test meal, and this can also be utilized to support or detect the presence of an EGJ obstruction. Most notably, this comes from work from Mark Fox and colleagues. And the standardized test meal potentially reflects more of a real-world scenario than just using the small volume liquid test swallows that typically makes up the basic protocol of the manometry test. And further, utilization of the standard test meal may help pull out or detect abnormalities that are not appreciated with these small volume single water swallows. We can see this in this example here, when this study has a fairly normal looking, several normal swallows with single test swallows, but with the solid test meal, see that the IRP is elevated and pressurization occurs related to the swallows that may detect an outflow obstruction. Further, the use of the meal actually allows patients' symptoms to be elicited. And looking at an association of symptoms with manometric findings may help support which abnormalities of motor function and abnormalities in esophageal physiology are associated with symptoms, and thus potentially provide another way to direct therapy. However, in a study of 750 patients, there were 151 such patients, so 20% of the entire study carried a new diagnosis of EGJ outflow obstruction based on a standardized test meal beyond the single water classification. So a really profound increased detection rate using this maneuver. And so this does bring some questions as to potential specificity and clinical relevance of this finding across this large spectrum of patients. So there is some balance that needs to be considered here. And ultimately, the consideration for mechanical esophageal obstruction, particularly if LES relaxation is normal on these single water test swallows, should be considered, as does pressure artifact. Further thinking about this balance of sensitivity and specificity with this expansion of the manometry test protocol is highlighted by a study that we performed looking at 30 asymptomatic volunteers. These were patients who were all healthy and just recruited for a research study. And when we used an extended protocol that used supine swallows, upright swallows, viscous swallows, solid swallows, multiple rapid swallow, and the rapid drink challenge, we saw that over a quarter of these patients had some elevated IRP values across these maneuvers. However, none of the patients had an elevated IRP on more than 2 maneuvers. Thus, these provocative maneuvers are useful, and they certainly can help enhance the high-resolution manometry test. But overall, seeking consistency in abnormalities is important, and they all ultimately likely serve a complementary role to the single test water swallow to overall generate a cumulative assessment of the manometry and the clinical relevance of the finding. However, ultimately, it's also important to recognize that high-resolution manometry may not be the end of the road in the patient evaluation to reach a conclusive and clinically relevant diagnosis. And in scenarios where HRM findings or classifications are inconclusive, complementary testing with modalities beyond high-resolution manometry may be essential. This may first involve incorporating even patient symptoms and the thorough endoscopic exam, but additional tests such as time barium esophagram, the functional luminal imaging probe or FLIP, or ambulatory reflux monitoring all may serve a role to help identify specific disease states related to esophageal symptoms. With barium esophagram, this provides both an anatomic and functional assessment of the esophagus, and that functional evaluation is enhanced with the application of a timed barium esophagram protocol, in which a standard volume is ingested and pictures are taken at standard time intervals, typically 200 cc's of barium, and the image is taken at 1 and 5 minutes after ingestion. Additionally, use of a standardized solid bolus, such as a barium tablet, can also help provide that objective assessment of function. Additionally, the functional luminal imaging probe, or FLIP, is a device that measures esophageal luminal diameters in response to controlled distension and also measures secondary peristalsis. Now, both esophagram and FLIP can be extremely useful in the setting of the manometric EJ outflow obstruction to help clarify the clinical relevance of that finding. Though additionally, ambulatory reflex monitoring may also need to be used to assess for GERD. And this, as acid reflux can actually induce esophageal motor findings, such as esophageal spasm. And finally, I'll close with a brief discussion on an additional component for manometry, which is using combined impedance with high-resolution manometry. Now, impedance manometry has been available for years and represents another method that can help complement the high-resolution manometry evaluation through its evaluation of bolus clearance. Additionally, using impedance can help identify the presence of bolus, and this can augment the measurement and evaluation of intrabolus pressurization, which is another important factor to include in the evaluation for EGJ outflow obstruction. But there are other additional novel applications of impedance manometry, such as pressure flow metrics that are described by the AIM analysis led by the group from Adelaide. And additionally, other novel metrics, such as the esophageal impedance integral, or EII ratio, can help enhance the evaluation for bolus clearance and retention. Where they fit in the overall application is still a focus of ongoing work, but they also appear to reflect useful advances to help complement the overall HRM study. So in conclusion, high-resolution manometry and the Chicago classification represent the state-of-the-art for esophageal motility evaluation. Advances over the past several years are reflected in version 4.0 of the Chicago classification that will be formally launched in a few weeks. Identification of achalasia remains the most important directive of an esophageal motility evaluation, and the HRM achalasia subtypes provide useful prognostic information and help direct targeted therapy. Additionally, an expanded HRM test protocol with 2 patient positions is essential, and provocative HRM maneuvers can further complement the manometric test to overall enhance the diagnostic impression. However, it's also important to recognize that HRM can potentially yield inconclusive results, and in these situations, additional complementary testing with barium esophagram or FLIP may be necessary to ultimately reach a clinical diagnosis. And with that, I'll thank you for your attention